Greetings! Welcome once more to my channel, to the series where we resolve USMLE-like questions I wrote myself, but that somewhat resemble what you would find in the USMLE or in a med school test. So today we have a pretty quick question about dermatopathology, which is a topic the USMLE particularly quite likes. It seems something somewhat simple, and so the way they sometimes make it a bit harder is by not just giving you alternatives like intradermal, subepidermal, or something like this, but rather showing you an image and asking, can you identify which of these images is what you're looking for? So this happens quite a lot, and this is a classic question. So, question 3. A 42-year-old male patient comes to the clinic due to recent appearance of multiple blisters on his torso and mouth. He takes valsartan and hydrochlorothiazide for hypertension and allopurinol for gout, and denies starting any new medication in the last year. He has no known allergies. Physical examination shows erosions on the chest, shoulders, and mouth, with a few unruptured, fluid-filled blisters. Pressing against the patient's skin causes it to slough off, creating a new lesion. A skin biopsy is ordered to confirm the diagnosis. Which of the following was most likely seen on this patient's dermatopathology? So here we have 4 microscopy slides. I will show their references as soon as we solve the question, otherwise I will give spoilers to what each of them is. And so, first thing here, you have to know which disease you are talking about. So okay, first thing, when you are talking about blistering skin diseases, first thing, age. Are we talking about a child, about a newborn, or are we talking about an adult, particularly an elderly patient? And this one is clearly an adult, not quite an elderly patient, but okay, 42-year-old male. So the first thing we can think is that if he is not a child, if he is presenting these blisters for the first time with 42 years old, this is most likely not genetic. He wouldn't present it for the first time at 42 years. So we are most likely thinking about an acquired blistering skin disease, which is most likely going to mean an immunobullous disease. Of course, we could have an infectious disease, for example, but it will usually present with very clear characteristics. For example, if it said he had a dermatomal rash on a single side of the body, for example, with pain, then you could think about zoster, which is caused by varicella zoster virus. However, if we just have this somewhat inspecific explanation of multiple blisters on his torso and mouth, so there's no clear history to this, and there's no specific location for the blisters. So we are most likely thinking about an immunobullous disease. And of course, the rest of the story is going to substantiate our belief here. So he mentions here that he's taking some pretty normal random medications that we wouldn't expect to cause any side effect like Steve Johnson syndrome, for example. So this is pretty much to rule out anything that could resemble toxic epidermolysis necrosis or any of these severe hypersensitivity syndromes. And it also says that he did not start any new medication the last year. So, yet again, no evidence of allergy here. He has no known allergies, once more emphasizing. Then physical examination shows erosions on the chest, shoulders, and mouth. And here with a few unruptured fluid-filled blisters. And here we have two key points we want to take notice of. The first is that mostly erosions were found, not really blisters. Most of the blisters were already ruptured and presenting as erosions. What this tells us is that these blisters were delicate, they are friable, they ruptured pretty easily, so that when the patient came to you, they were already ruptured. So we are thinking about a disease that causes multiple delicate blisters. And the second point we want to notice here is that shows erosions on the chest, shoulders, and mouth. And so this indicates mucosal involvement. There are not that many diseases that involve the mucosa with blisters. So here what we are pointing towards is an immunobullous diseases, and specifically towards pemphigus vulgaris. And the difference that tests, and particularly the USMLE, really like is to ask you to differentiate between pemphigus vulgaris and bullous pemphigoid. And it's not really that hard, but I guess people get confused in it, because pemphigus vulgaris is, so to speak, the more severe presentation. Since the blisters are more superficial, they rupture more easily, and they also almost always, very often, involve the mucosa, sometimes only the mucosa. Whereas bullous pemphigoid has more tense blisters that don't rupture that easily, and it does not involve mucosa. So, since he is a 42-year-old male patient, we are going to completely ignore anything like, for example, epidermolysis bullosa. We are going to ignore the gynodermatosis because it's not a newborn, not a child. Second, we have the sudden appearance of multiple blisters on multiple locations. It doesn't seem it's an allergy, and we also don't have any characteristic to believe it's an infectious disease. So we're going to assume it's an immunobullous disease. And what's going to aid us in this diagnosis is the characteristic presentation with mucosal involvement and ruptured blisters. So we are already thinking, well, this looks like pemphigus vulgaris. What actually pretty much closes our diagnosis, what makes us sure we are going on the right trajectory, is this. Pressing against the patient's skin causes it to slough off, creating a new lesion. So you press and you twist, or you press and push, and the skin sloughs off. What this means is that there is some kind of, so to speak, instability inside the epidermis, intraepidermal. So for some reason, different layers of the epidermis can detach from each other, and pressing against the skin causes them to detach, forming a new blister. So this points us towards an intraepidermal lesion. This is called Nikolsky sign, if you like the eponym, and this is present in some kinds of intraepidermal blistering skin diseases, such as pemphigus vulgaris, and some types of epidermolysis bullosa, for example. Although epidermolysis bullosa has all kinds of different variations. But here we are not talking about gynodermatosis like epidermolysis bullosa, because this is not a neonate, this is not a child. So, when we see Nikolsky sign with mucosal involvement in a 42-year-old male patient, we are thinking about an intraepidermal blistering skin disease in an adult, and this is pretty much surely pemphigus vulgaris. Since we are talking about an adult, we most likely think pemphigus vulgaris or bullous pemphigoid, but bullous pemphigoid wouldn't have mucosal involvement and wouldn't have Nikolsky sign. And so, the next part now is which of the following was most likely seen on this patient's dermatopathology. And this is pretty much asking you, can you identify an intraepidermal blister? Okay, you know it's pemphigus vulgaris, that would be too easy. We've talked about mucosal involvement, we talked about Mikulski sign, you already know it's pemphigus vulgaris. So, which of these represents the finding in pemphigus vulgaris, that is, intraepidermal lesions? And so, if you want to take your time and look at the options, pause the video. I'm going to keep forward. So, the correct answer here is going to be B. On B, we can see intraepidermal lesions, and actually the picture name is Clinical and Histological Characterization of Oral Pemphigus Lesions in Patients with Skin Diseases. I took this from a study on PubMed. So, on A, you are seeing actinic keratosis. You can see here that there is parakeratosis. This is not that much important for you because after all, you're not going to see findings such as atypia or parakeratosis with this magnification. You are not going to see this. So, what you should be looking for are blisters, pemphigus vulgaris. And the only place we see blisters at are alternatives B and C. So you already know it's not A, G, or E. But for completion's sake, here on A, what you can see above all else is that there is a lot of epidermis here. The epidermal strata are extremely increased. There is a lot of the epidermis in this place. And even if you can't really see if it's because of the stratum corneum with this magnification, we are going to assume this is hyperkeratosis. And so, A, you don't see any blisters, you just see hyperkeratosis. This is actinic keratosis. Then we have B, which is our correct answer. And what you can see here is that we are seeing the epidermis and the dermis. And of course, this is going to be slightly different from what you might expect. Where is the keratin? Well, we're talking about mucosa, not skin. But in any case, you can see that there is the epidermis up here, and lower there is the dermis. However, what we can notice here, even if it's not completely linear, it's not that clear to see, but you can see that the blisters are appearing inside the epidermis. They are appearing between, they are forming between likewise cells. The dermo-epidermal junction here is intact. You can see that the plates where the dermis and the epidermis meet has no blisters. The blisters are above it. The blisters are completely inside the epidermis. So here we have intraepidermal blisters, and it's precisely because they are more superficial, they are intraepidermal and not subepidermal, that they are more delicate and that they slough off easily. That's why we have the erosions, and that's why we have the Mikulski sign. So this is our correct answer, B for pemphigus vulgaris. Then we have alternative C. Don't be confused by the large B on the image. This comes from the original paper. And here we have bullous pemphigoid to contrast it. Okay, both images are in different magnifications and they are of different places for biopsy. Doesn't really matter. What really matters is that here on image on option C, what you can clearly see is that the blisters are forming precisely between the epidermis and the dermis. They are detached. Contrary to what you see on alternative B, where the blisters are forming between cells that are pretty much the same, that are likewise, here on alternative C, you can see that the blisters are forming at the exact place where they need to be to split to different components of the skin. So here we can see the blisters are between the epidermis and the dermis, and these are subepidermal blisters that would be found, for example, in bullous pemphigoid. However, subepidermal blisters are not as delicate and will not present Minkowski sign and also not involve the mucosa. Then, here on alternative G, you have keratin pores, these swirly findings here in the middle, and this is actually not even skin, this is from the larynx. This is a squamous cell carcinoma of the larynx slide. However, you are probably not going to be confused by this one, but the clear finding here is that you have these keratin pores, these local depositions of keratin, and since it's keratin, it's most often found in squamous cell carcinomas. So you find keratin pores, think squamous cell carcinomas. Maybe it could be a carcinoma of the skin, although not specifically on this slide, but that's just what we're searching for. Carcinomas of the skin will not form blisters. And finally here, on alternative E, you have a verruca vulgaris. And maybe you've never seen a slide of verruca vulgaris, but you already know there are no blisters here. Again, for completion's sake, what you can see on this slide, what you can notice, is how much keratin there is here. Look at this huge amount of keratin, and it's overlying these papillary-like projections of the epidermis. So we have these papillary-like outward projections and a lot of keratin over them. So this is a verruca vulgaris. This pretty much is a classic question with a small twist on it, which is asking you to identify the image. And it's primarily about to identify blistering skin diseases, and then what the USMLE loves, differentiating between pemphigus vulgaris and bullous pemphigoid. And clinically it's going to be about mucosa involvement in Minkowski sign, whereas on microscopy it's going to be about where the blisters are, subepidermal or intraepidermal. Thank you for choosing to spend your time with me. I hope this has been useful. I already have other questions on the way, so if you are interested, consider coming back next week. This is not medical advice, this is just a question resolution. Thank you once more for choosing to share your time with me, and I hope to see you on the next video.